All right. Tricuspid Atresia. This is kind of a bizarre one where basically the tricuspid valve does not develop. So you end up having the right ventricle becoming hypoplastic because it doesn't develop because there's no blood flow going to it. And you basically have to have a connection between the right and left atrium because that's how blood flow is going to be pumped through the ASD out to the rest of the body, which means you're going to have a little bit of a cyanotic defect. Blood also passes through the ductus arteriosus or through a VSD to go to the lungs. So this is again one of those diseases that you have to have the PDA being maintained open. Here you can see there's no tricuspid valve. It's atresic, so you don't have any connection between the right atrium and the right ventricle. There's a rudimentary right ventricle that is present, but the predominant thing is that you have a left ventricle then that pumps blood both through the pulmonary artery and through the aorta. Okay. Got to have a right an atrial septal defect, otherwise you'd have no connection. Clinical manifestations are obviously going to have a huge systolic murmur on the due to that VSD. You're going to have left axis deviation because the left side of the heart is the predominant portion. The heart size itself doesn't necessarily increase, but you do have it being predominantly that left ventricle. And amazingly, we diagnose it with echocardiography. Yes, Susan.
Was that picture, is it just like one big ventricle? Is that what it looked like? Okay.
You're just going to have a left ventricle. You don't have any right ventricle there. It just doesn't develop. Treatment is prostaglandin. I believe in the prior slide there was make mention of a prostaglandin inhibitor. No, that's wrong. You give a prostaglandin to maintain the PDA. Okay. I don't care which prostaglandin it is, just know that we give them to maintain that ductus arteriosus staying open. We'll do a Blalock-Taussig shunt so that we have blood flow going to the pulmonary system, because you don't have the pulmonary artery receiving the predominant amount of blood. And we'll find it's something called a hemi-Fontan or a Glen procedure or a full Fontan, and I'll explain what those are when we talk about the next defect. We have to manage these. And then there's the granddaddy, what I like to consider the most bizarre and most difficult to manage of all the cardiac defects. My favorite is still tetralogy of Fallot, but this one is a bizarre one also. Hypoplastic left heart syndrome. It's a kind of a one that is on a continuum, and what I'm going to paint is kind of the worst possible picture, but there's different levels of severity as far as how severe some of these are. For instance, a coarctation of the aorta. Sometimes it's just that the aortic arch doesn't fully develop and it's hypoplasic, meaning it's reduced in size. Sometimes there actually is a coarctation. Bottom line is that you also have all the valves on the left side of the heart, the aortic valve as well as the mitral valve. They can be stenotic, they can be atresic, they can be defective in multiple ways, and that's all leads to the left ventricle becoming hypoplasic, meaning it's small in size. It is a cyanotic defect, and it's that way because the right heart has to pump blood through the ductus arteriosus to the rest of the body. When you see the picture, you can kind of maintain that. Closure of the PDA would be death for the child because they're not getting any blood flow to the systemic circulation. So this is one of the unique ones where we not only do things to keep the PDA open, it's a balance between the pulmonary vascular resistance being slightly higher than the systemic vascular resistance. In other words, the pulmonary pressures have to be slightly higher than the systemic pressures. It's a very narrow range that you're working in. Anytime you have the PaO2 rising, you have the pulmonary vasculature relaxing and the PA pressures fall, you don't get blood flow going to the systemic circulation. So it's this balance that we have to strike. And this is one where basically we promote hypoxemia, and in some cases, at least in the preoperative phase, we want to maintain a little bit of a hypercarbia, but after surgery, we want to keep this hypoxemia there until, we want to normalize the CO2 and put them in what we call the 40-40 club, where hypoxemia is maintained at 40 and the CO2 is normalized at 40 also. So let's take a look at the picture here. You have a very small aorta, a hypoplasic aorta, coming off a hypoplastic left ventricle. You end up having often some defect either in the aortic valve or in the mitral valve. Got to have ASD present for blood to get back, especially if this is atresic in nature, to get back to the right side of the heart in some fashion. And the PDA, again, has to be maintained. You can see the aortic arch is very rudimentary in nature. It's very, very small in nature because there's not a lot of blood flow going through it. Just another picture of it here. You can see that the left ventricle doesn't generate much pressure at all. In fact, it often doesn't generate any. Pulmonary artery pressure is always higher than systolic or systemic arterial pressure. So we have blood flow going through that PDA. Gotta have that. Just another picture of it here. They got a patent foraminal valve. You got, in this case, coarctation of the aorta. You can have a ductus arteriosus, is where the primary amount of blood is going to the systemic circulation. Narrowed aorta, the hypoplastic left ventricle, and the aortic atresia. Those are all combinations that you can end up having. The right heart in this defect is how blood gets everywhere. The left side of the heart is totally useless. Okay. This is out of your text talking about the different corrective mechanisms. And we'll talk about the Norwood, the Glen, and the Fontan as we go through. There are 3 separate surgeries, so these are kids that we see coming back time and time again. The Norwood procedure is the very first one, and that's done right after birth, as quickly as possible, because we want to be able to create a mechanism by which blood flow goes to the systemic circulation more effectively. Again, the PDA is maintained open through the use of prostaglandins. And if the ASD is not large, they'll go in and actually use what they call a septostomy. They'll end up making that septum open with a balloon. They create a bigger ASD because you got to have that there also. The other thing they need to do is maintain a reduction in the pulmonary vascular resistance. Let me rephrase that. You want to maintain that PVR as being elevated, and we do that by causing hypoxemia. We'll actually use somewhere between 14 and 21% oxygen. So we purposefully use a reduced FiO2. It's one of the rare times we end up doing that. And the second thing we end up doing is creating a little bit of hypercarbia. Elevations in the PCO2 cause an increase in PVR also. It's kind of a secondary side effect. So in order to do that, we may hypoventilate, or we may actually administer an inspired carbon dioxide. So bleed CO2 into the inspired gas. Like everything we teach you not to do, we do. Because you want to maintain that process. So the Norwood is the first one that is done. Then at about 3 to 9 months of age, we do what is called a Glen shunt. And then finally we do the Fontan. And the Fontan is done usually later, a couple of years of age. We want to do it as quickly as we can to be able to reduce the amount of pulmonary hypertension that develops, but we don't want to have it done before the heart's large enough for a growth standpoint. So, stage 1 is a Norwood. And in this one case, what we do is we literally take the pulmonary artery and attach it to the aortic arch. You can see the little stitches that are there. We surgically attach it. And then what we end up doing is we don't have pulmonary blood flow anymore. So we create a Blalock-Taussig shunt between the right subclavian and the pulmonary artery itself. So the pulmonary artery is no longer getting blood flow. The lungs are no longer getting blood flow from the pulmonary artery. They're getting it indirectly through the Blalock-Taussig shunt. It's a very passive mechanism by which blood flow is going to the lungs. And again, that atrial septal defect is enlarged so that blood coming back from the lungs has an easier flow into the pulmonary, into the right side of the heart. This is the Norwood. Done immediately after birth or as soon after birth as possible because I want to get blood flow to the systemic circulation in the process. Stage 2 is called the Glen shunt. And this is where we want to increase the amount of pulmonary blood flow. Going through that Blalock-Taussig shunt is okay in the first few months, but it's not going to suffice long term. So what we do with this one is we take the superior vena cava coming back and we anastomose it to the right pulmonary artery. So all the blood flow coming back from the upper trunk goes to the pulmonary artery. Again, a passive flow. There's no heart pumping blood to the right side, and we end up having an improvement in pulmonary blood flow. That's a Glen. So Norwood, Glen, and then finally the Fontan. And the Fontan is where we take not only the superior vena cava, but also the inferior vena cava, and we anastomose them both to the pulmonary artery. Good Lord Almighty. What I have done now is I basically have taken and recreated what should be the heart surgically. I'm taking all my blood coming back from my body and I'm directing it to the pulmonary artery without going through the heart. So again, it requires a passive mechanism. All the blood that is going to the systemic circulation is going through what was the pulmonary artery that's now been anastomosed to the aorta. So we have basically doctored this all up in the process. These latter two, just as an aside, I won't ask you this, but if you get into pediatric surgery, if that's where you end up in a PICU and you see these kids all the time, the latter two stages, the Glen and the Fontan, because they have now lots of blood flow coming back to the pulmonary system in a passive mechanism, positive pressure ventilation is evil. Because any increase in intrathoracic pressure is going to reduce the blood flow coming back into those areas. So we try our best to wean these kids as quickly as possible. Not that common. I don't have a number as far as how many live births this ends up in. I'm guessing maybe 10,000, 1 in 10,000. But if you're working at Children's Hospital, you're going to see these all the time because every other hospital doesn't do them. It's kind of just unique centers. So you go to Mott, you go to Children's, you go to Spectrum. I'm trying to remember the name of the Children's, DeVos Children's Hospital. Those are places where you'll end up seeing them and you say, my God, I see these all the time. Well, that's because there's nowhere else to go. So they're kind of locked in there. Okay. And this says, how many times have you just thought, if I just close my eyes, the bitch will go away.